But I wanted to hand things over to Dr. Kathleen Stephanos. Kat is a graduate of our EM PEDS program in 2016. She's faculty up at Rochester now. And she's going to spend a bit of time talking about COVID in pediatrics, which has been making the news quite a bit in recent days. And if Mimi's available afterwards for some commentary, we might get Dr. Mimi Liu, who's also a graduate from 2008 in Ben's class. He graduated in 2008, if I didn't say that. And I know Mimi's in the midst of some other work also, so we'll see. But Kathleen, looks like your slides are coming up, and I'll just hand things over to you. So thanks for joining us.
Great. Hi, can you hear me?
Yep.
Okay, great. So yeah, thank you. It's great to send me back, though I'm actually back in Baltimore quite frequently because my whole family is still there, my extended family. I think the best part of COVID so far has actually been reconnecting with all of my classmates from residency via email, chats, and whatnot. And as Amal said, I'm up at University of Rochester and we're gearing up for some snow this weekend. Oh, there we go. So this is me up in our tent. We have a tent set up to evaluate primarily adult patients who are coming in with respiratory symptoms. And I actually split my time about 60% pediatrics and 40% adults, all in the emergency department up here. So I'm going to touch base and kind of go over some of the things with pediatrics. So fortunately, most of the pediatric patients kind of get through this like a boss. No problems at all, end of story. They do great. That's it, right? But not completely. So why we really care, there's about 74 million pediatric patients in the United States, so a pediatric population that's under the age of 18. And there's less than 4,000 PICU beds, which equates to about one for every 19,000 pediatric patients, which overall is a pretty sufficient number of PICU beds. But when you compare that to the adult patient population, it's substantially less per capita. And it's typically not much of a concern, but with the 74 that were in the hospital admitted to ICUs back in April, there's been some estimates that if there's a surge, we could also see a pretty big issue with pediatric patients as well. So along with that, fortunately, the fatality rate is pretty low, 0.1% fatality rate overall with pediatrics. And of note, about half of the pregnancies that are being affected by COVID are resulting in preterm births. So something else to keep on the horizon, that we may be seeing an increase in preterm deliveries. But also why we really care, I mean, we all know this is how children sneeze, and this is how children play. So this is the biggest issue that we have in pediatrics, is that everybody's sort of on top of each other. Overall, the epidemiology in pediatrics is showing about 2% of the cases being within a pediatric patient population. Some initial data was suggesting that there were increased levels of male patients versus female. But overall, 90% have a mild or even asymptomatic presentation of the disease, but up to 6.7% have a severe form, which includes requiring admission, potentially intubation, though more often it's significant hypoxia requiring oxygen, including high flow. And of that, when you get into the smaller patient population, so children under the age of 1, it's actually even higher. So up to over 10% of children under the age of 1 will have some sort of complication requiring admission. Fortunately, when we're looking, some of these studies are showing that children actually are less likely to contract COVID. So not that they're just asymptomatic, but they're just not getting the disease. They also tend to recover a little faster than adults. So a 1 to 2 week recovery, so sort of typical for things like rhinovirus, as opposed to adults, which have a much longer recovery time period. These graphs are showing, the top graph is pediatric patients who are having symptoms of the disease, and then the second one is when they were diagnosed. So there's a lag time very similar to an adult patient population. Overall, the symptoms tend to be very similar to adults. About 59% have a fever, 46% have a cough, 15% have congestion, 12% have some GI symptoms, and 26% have no symptoms whatsoever. So there's also some patients with sore throat, there's congestion, rhinorrhea, and other vague non-specific symptoms, headache, similar to adults. In pediatric patients, we often don't really need laboratory testing other than testing for the COVID itself. Typically, lab values will be completely normal. That's the vast majority of these patients if you were to test them. 32% will have some lymphopenia, 9% will have severe lymphopenia, and some will have some increased procalcitonin, though most people believe that this is actually more related to secondary infections as opposed to the COVID itself. If you need to get imaging, most of the original studies were still CTing everyone, including children. These were out of China. I do not recommend routine CT scanning for any child, but if you're getting imaging, probably a chest x-ray is about all you need. You may see some diffuse opacities. They're often very nonspecific. And as I said, the CT may show some consolidations and ground glass opacities very similar to adult patients, but overall is really not necessary for the diagnosis or treatment in children. This is the biggest factor. So lately, there's been a lot of things coming out about these secondary infections in children. I think in the last week, this has sort of hit a lot of the news. So about 11 cases in the UK and 15 cases out of New York City are showing this maybe Kawasaki-like disease or toxic shock-like syndrome. So it's still on this sort of vague spectrum at this point. If you recall, Kawasaki is a believed to be post-viral autoimmune vasculitis affecting multiple organ systems. Notably, the crash and burn, so conjunctivitis, rash, lymphadenitis, the strawberry tongue, and hand and foot edema are sort of the characteristic findings of Kawasaki. But these also sort of fall right under toxic shock as well. So a lot of the similarities exist between the two diseases. And I think we're still trying to figure out which exactly disease process is happening. As I mentioned, Kawasaki is associated, we believe, with a post-viral syndrome. Interestingly, in the past, long before COVID even existed, people thought that Kawasaki may be connected to coronaviruses specifically. So that makes sense that this would be a finding in patients who have COVID as well. Importantly, what we're really seeing, what the things that people are being alarmed by is Kawasaki shock syndrome, which is all the symptoms of Kawasaki in association with hypotension. And with all of the Kawasaki patients, the thing we're most worried about is coronary artery aneurysms, which is the main complicating factor that can result in severe cardiac dysfunction. This includes, there's pericarditis and myocarditis associated with it as well, and this sort of systemic involvement. So these patients may present like a septic shock patient with all of these other features as well. And Kawasaki overall is an underdiagnosed disease. So it should be something considered very regularly in general in pediatric practice, and maybe being missed a lot right now due to patients being more concerned about COVID or even sepsis in these children. So the management overall for pediatric patients, it's very similar to adults in terms of symptomatic management. However, there are no medications currently approved or under testing for pediatrics, so nothing has been approved for use in children. However, if you are concerned about a Kawasaki type syndrome, the mainstay of treatment is IVIG, as well as aspirin, which is unchanged for these patients versus prior Kawasaki diagnoses. In these patients specifically, IVIG may be required more than once for symptom control, which is not as common for just simple Kawasaki. It happens a little more with these Kawasaki shock syndrome patients. So stepping back from that, I think the biggest problem we find in the pediatric emergency department is actually the worried and relatively well patient. So oftentimes parents come in very worried. I think this is why a lot of people don't go into pediatrics, is because they don't want to deal with the parents, but we have to. So if you come in and you have a patient who's actually looks pretty good and can go home with COVID, or if there's some concern for COVID and you're not testing, depending upon your local environment, I found that some of the helpful tools are actually, first, comparing it to the flu. Don't say that it's like the flu, but when you compare it to the flu in terms of the number of kids who are super ill, you actually can sort of calm parents down. So I've told parents, look, there's 74 patients, that's back in April, but 74 patients admitted to the ICU in the entire United States. That is less patients than I've admitted for flu in the last year to our hospital. And that seems to help families. And then you go on to remind them that they need to vaccinate their children, including against things like the flu, because the flu is much more likely to kill a child and have significant complications than COVID. Along with that, making sure that they are staying home and staying safe and wearing masks. Though an important feature to this mask concept, these are all of my children, but technically this one should not be wearing a mask. Children under the age of 2 should not be wearing masks. So it's important to remind families of this. Children under 2 have a risk of suffocation. As in addition, they may have strangulation issue because oftentimes you need to tie the mask around the back of their head in order to get it to stay on a child of this age. And technically pieces of the mask might come off and they could choke on it, though that would be a little harder than the other 2. So under 2 don't need a mask. The other important factor for pediatrics, and probably for everyone in general, are the indirect effects of COVID-19. And children are now home. They are in an environment where they aren't going out to schools, they're not getting exercise. So this can have a significant impact on mental health because of lower socioeconomic situations. They may not be getting the appropriate nutrition or hydration. And in severe cases, neglect may be occurring at home, or in the worst case scenario, frank abuse that's not being identified by schools or as on routine doctor's visits. So when I talk to my colleagues who specialize in child abuse, they're really fearful that a lot of injuries are going unnoticed. So we should be a lot more heightened in our awareness for this in the presentations to the emergency department, because they are a very vulnerable population who are now isolated in situations where they may not be under the best care. So, but of course, like with everything in COVID, everything is changing on a day-to-day basis, and we're learning more and more, a lot more to come. And any questions?
Great, thanks, Kat. I don't know if Mimi is still on the line. Mimi, if you're there, did you have any additional comments?
Hi there. Great to see everyone. Just a reminder to the residents how awesome we have an alumni network that's across the nation and the world, really spreading wonderful information and sharing their knowledge and expertise, all coming from this program. So thank you to all the previous speakers and the upcoming speakers. Kat did a great job in summarizing a lot of the upcoming and relatively new evidence that's coming out in peds. Small subset, overall very, very generally tolerating it well, less than 1% in the total number of patients who have, and very few have died altogether. Couple in the US, but a study that came out of New England Journal, small percentage, 0 deaths. Small percentage of very ill pediatric patients and almost 0 deaths altogether. But there was a question that I saw about super spreaders. Various theories abound, some of it being just general exposure to various coronavirus types previously that may have conferred some relative immunity, is one of the theories out there. And that constant exposure and the lung epithelium and the ability of the virus to attach, causing them to have less severe symptoms overall, and thus being probably asymptomatic spreaders, may be one of the theories that's currently out there and postulated, but not a lot of great information on treatment other than supportive care. And Kat had some great reminders about being aware of potentials for abuse, and during these trying times that are definitely heightened stressors for the families, being stuck at home with these kids all day long when they've previously been able to send them to school and having to learn all these new platforms of home education. So thanks, Kat. And
I'm sorry, go ahead.
no, sorry, nothing for me.
I was just going to say, I see a question from Mac. Mac, do you want to unmute and shout out your question?
This isn't necessarily a pediatric question, but has anyone, especially maybe Stephen Liang, there's this concept of hemoperfusion and specific cartridges to basically, like, take out these bad humors, the cytokines and interleukins. It clearly has nothing to do with emergency medicine, but we keep talking about the lack of evidence for everything. This is something that I've come across in Chinese sort of publications, which may not have as rigorous peer review, but in any of our maybe ICU folk or Stephen Liang, someone talk about that modality of treatment, maybe outside of this, after we finish the pediatric conversation?
Okay, sure. I do have one Pete's question for Kat and Mimi. With regards to this Kawasaki-like syndrome, is that going to just be a clinical diagnosis in the emergency department? And if we suspect it, should we assume that all these patients are automatically admitted? And is there anything that we should be starting them on in the ED? I guess that's a multi-part question.
I would say, so yes, it's a clinical diagnosis. Oftentimes the ones that we're hearing about are more the Kawasaki shock syndrome. So they're going to get started on full sepsis protocol and workup as well, which is why there's that overlap with maybe toxic shock is what they're trying to figure out at this point. I don't know, most places are not initiating IVIG in the emergency department. That's typically done, depending upon your institution, with either rheumatology or infectious disease or cardiology. Different places have different people managing that. So I don't know, IVIG doesn't need to be started immediately from the emergency department.
All right, and I see, let's take one last question. Actually, Mac, with your question, can we save that to the critical care thing at the end and maybe give people a little chance to think about it? Also, Steve had to step out, so hopefully he'll be back at that point. But Beatrice had a PEDS-related question. Let's see, any thoughts on the concerns about parents skipping vaccine appointments due to COVID, leading to declining vaccination rates? And are you aware of any ongoing efforts to counteract this? That's an interesting question, that vaccines are so important, yet the lack of primary care appointments right now may be a concern down the road. Any thoughts about that?
The current guidelines, according to the AAP, are that all practices remain open to vaccinations for well children. So they're not supposed to be skipping these, although parents may be. I don't know that there's any specific campaigns to encourage it. Though some places are doing like drive-by vaccinations, so families can feel a little more secure. Then a question about why volumes are so low. It definitely is low, I think, because kids are not getting sick from each other in schools. And they also aren't getting injured. They're not participating in sports. So we have everyone at home isolated. So they're not getting sick and they're not getting injured. So that reduces our asthma, that reduces fevers, that reduces everything else. We've seen a few dog bites because the dogs aren't used to the kids being home. And yeah, but I think yesterday there was a Chinese study that came out suggesting that kids have a 3-fold increased human-to-human contact ratio compared to adults once they're back in schools. So we'll see. It'll be interesting when schools reopen.
Okay.
The other, a lot of pediatric offices have also increased their teletriage capabilities. And because kids don't tend to be sick, they've been able to encourage parents to stay home. And parents are, I think, deathly afraid of bringing their children to the COVID environment, similar to the STEMIs and strokes that are staying home as well.
Okay. Let's take one last question. This is from the PICU team. Would you recommend admitting PEDS patients who clinically would not meet admission criteria? I guess the vitals are stable, no O2 requirement, but have a very elevated D-dimer and CRP. Should we be admitting to monitor for worsening status and to give prophylactic anticoagulation?
I have not specifically seen that, the elevated D-dimer and CRP. I've actually we haven't had a huge number of pediatric patients. I don't know. Prophylactic anticoagulation is an interesting question for pediatrics because overall children under the age of 14 are much less likely to get major clotting disorders. But I don't know. Mimi, do you have any other thoughts on that?
I'm not aware of any of those protocols and prophylactic, either with prophylactic anticoagulation or prophylactic admission.
All right. Well, Kat, Mimi, thank you so much. Why don't we take our next break, and we'll start up in about 7 minutes.